بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll continue the lectures about skeletal fractures. We have finished the fractures of the upper limb, and now we are going to discuss the pelvic fractures as well as the lower limb fractures. And we will try to outline these topics. First, we'll deal with the types of fractures of the pelvic bones. Then we have some words about hip joint dislocation, slipped capital femoral epiphysis, femoral neck fractures, distal femoral fractures, Pellegrini stida lesion, knee joint dislocation, patellar fractures, tibial plateau fractures, tibial shaft, fractures around the ankle, and finally we'll have the fractures of the foot. Fractures of the pelvis are usually classified into three major types, and also we have the simple fracture, which is not included in these three main groups. Then the femoral neck fractures include the intra-articular and the extra-articular fractures. We have the subcapital, transcervical, basicervical, and the capital fracture, intertrochanteric fracture, and subtrochanteric. And foot fractures, we will deal with Lisfranc fractures, Shepard fractures, avulsion fractures, snowboarders fractures, Jones, calcaneal fractures, and finally the stress fractures. And you know that the pelvic bones are aligned in a certain way so that the direction of trauma will affect the type of a pelvic fracture. These fractures can be simple, meaning that there is one fraction of one of the pubic rami, the ischium, or the iliac bone, for example, and a complex type of fracture, which is a group of fractures entitled under a certain name. Then the low energy simple fractures may include acetabular fractures, pubic rami fractures, iliac wing fracture, and this is an example of a simple fracture involving the ischium on the left side, and this is also an example of a simple fracture affecting the iliac bone on the left side. Then we'll discuss now the major types of the pelvic fractures that are complex and require usually high energy force, and these are the anteroposterior compression fracture, which is famously known as the open book fracture, then lateral compression fracture, sometimes known as windswept pelvis, and the vertical shear fracture or the bucket handle fracture of the pelvis, sometimes known as Mulgagny fracture. Then this video, I think, is one of the interesting videos that can help you to understand these types of fractures in a simple way. Then
Pelvic fracture overview. Anatomy, you find here the SI joint, the ischium,
then we'll continue.
Pubic bone, symphysis pubis, ilium, sacrum, and the strong sacroiliac ligaments. The sacroiliac joint have posterior ligaments that is very strong, and the stability of the pelvis depend on the integrity of the posterior weight-bearing sacroiliac joint complex and transfer of the weight from the spine to the lower extremity occur through that joint. is a ring. When a force occurs, it will injure the ring in the front and the back. The anterior injury and the posterior injury. The anterior injury is usually obvious, will be noted on radiograph, and usually associated with a posterior injury or a fracture. The posterior injury could be occult. Always look at the back of the pelvis. Unstable pelvis will have a gap or comminution. The posterior fracture is serious. We need significant blood transfusion, we need surgery, and the outcome will be unpredictable. That posterior fracture is a serious injury that will lead to instability of the pelvis and a lot of bleeding. This bony instability, if it is not corrected surgically, it can cause late deformity, limb length discrepancy, and pain. Types of pelvic fractures. There are three types: anteroposterior type, lateral compression type, and the bad vertical shear type. The first type is the anteroposterior compression type. You can have that with a pubic rami fracture, as you can see here in the slide, or you can have it as an open book type. When the symphysis pubis opens up, we call it symphysis pubis diastasis. Treatment: close the book, pelvic binder or a sling, surgery if the symphysis pubis diastasis is more than 2.5 centimeter. The surgery can be done through an external flexor or a plate. This is an example of external flexor of the pelvis. This is an example of anterior plate. You can see here in the incision. After you reach the bone, you will try to reduce the disruption of the symphysis pubis. Then you fix the symphysis pubis with the plate. The lateral compression type. It is the most common type of fracture and is usually impacted and not displaced. It has a good prognosis, usually doesn't require surgical fixation. The third type is the vertical shear fracture. It is a bad fracture. It needs surgery anteriorly and posteriorly. It needs blood transfusion, extensive blood transfusion. Outcome is guarded. Initial external flexor may be needed to control the bleeding. You probably will use traction in the emergency room, which will reduce the vertical displacement and decrease the motion at the fracture site. You may also use a pelvic binder in the emergency room. Vertical shear fracture are stabilized surgically by anterior stabilization using plates. Reduction of the symphysis pubis is done before fixation. And here is the anterior fixation. Usually this fracture will need to be fixed posteriorly. We usually use posterior screw fixation. You can see a CT scan that shows the posterior screw fixation. All my videos and this video
Okay, we'll continue. I think this is a valuable video for you to understand the types of the pelvic fractures. And now this is one of the most important complications emphasized in the previous video, and is also emphasized here, which is the risk of massive bleeding, which requires blood transfer. Uh, Sometimes you need the blood to overcome the massive hemorrhage, and also there are many other fractures, but you should remember that bleeding is a major complication of the pelvic fractures. And I think this video will also emphasize this important knowledge for you that
Pelvic
bleeding is
fractures
a
with
very
bleeding.
important risk
Pelvic
of
fractures
pelvic
may
fracture.
cause significant bleeding. The sacroiliac joint has important anatomy to the superior gluteal artery and to the sciatic nerve. In addition to the superior gluteal artery, there is an important obturator artery in the vicinity of the pelvic bone. The superior gluteal artery is responsible for the majority of bleeding in pelvic fracture with arterial injury. However, most of the bleeding in pelvic fractures is from the veins and the fracture itself. Hemorrhage is the most life-threatening complication associated with pelvic injuries. It is usually hemorrhage of the superior gluteal artery. Approximately 10% of patients will have severe bleeding. Severe bleeding usually occurs in fracture patterns that are highly unstable to both rotational and vertical forces. The first type is ABC3, an open book-like type. You can see in the front the symphysis pubis diastasis, and sometimes it is the pubic rami that are fractured. In the back, the sacroiliac joint is totally disrupted and the pelvis is in external rotation. You can see here all the ligaments are disrupted. The second type is the vertical shear fracture. The hemipelvis goes up. It is a bad fracture. You can see most of the ligaments are disrupted from front to back. You can see the two types, the anteroposterior compression fracture and vertical shear fracture. These are the two types that will bleed heavily and will require a lot of blood transfusion. The mortality rate is directly related to shock at the time of presentation. Bleeding from the superior gluteal artery may be fatal. How do you treat patient with pelvic fracture and major bleeding? A decrease in the blood pressure of the patient indicates that the patient lost approximately 35% of their blood volume. Some of the treatment options available for us is immediate application of the anti-shock garment. It's absolutely contraindicated in patients with rupture of the diaphragm. Ringer's lactate is the preferred initial fluid replacement used to resuscitate hypovolemic trauma patient in shock. Hypotensive blunt trauma patients are usually given initial fluid push with 2,000 milliliter of Ringer's lactate. Patient with bleeding and in shock will probably require O negative blood. If the patient is given 4 units of blood but remains hemodynamically unstable, then that patient needs angiography and embolization of the major arterial bleed. Immediate application of an external fixer is another method to control bleeding, especially if the pelvis is unstable in external rotation. Abdominal and pelvic CT scan will clearly define the bony injury as well as the extent and the source of the bleeding. The best treatment for pelvic fracture with bleeding is a blood transfusion. All my videos and this video.
Okay, then we understand now the risk of bleeding in the pelvic fractures, and it is emphasized in many ways that whenever the patient is sustained for a sustained of a pelvic fracture, then you should look or you should be careful about the issue of bleeding. Then also we need to evaluate the perineum, the vagina, the rectum for detection of occult injuries. And also you should have to think about the presence of retroperitoneal hematoma as well. In these conditions, the head injuries and intra-abdominal injuries may be also suspected. Also, the involvement of the lumbar plexus may occur. And these are the types that were clearly demonstrated in the video. You have the open book compression fracture with three types according to the degree of diastasis of the pubic symphysis and as well as the associated posterior rim injuries. We have three types, the type 1, type 2, and type 3. Then this is an example of an open book pelvic injury. You see that the pubic symphysis is separated and posteriorly you see that there is some diastasis of the right sacroiliac joint. And this is also another example. You see there is an open book pelvic fracture with separation of the pubic symphysis, and also you may appreciate a fracture here in the inferior pubic ramus with disruption of the right sacroiliac joint. And the lateral compression fracture, or what's known as the windswept fracture, there is the injury is coming from one side compressing the pelvis like the wind bending bending the trees, for example, and hence the name windswept fracture. We have three types, the type 1 and type 2 and type 3 according to the injuries of the anterior pubic rami as well as the associated fractures of the iliac bone and the damage of the sacrum as well. Then a combination of unilateral EB compression, which is the open book injury, and contralateral compression injury, which is the windswept compression, will result in this type of trauma. And here you can see the bending of the iliac bone on the left side with disruption of both sacroiliac joints, and you can appreciate also this minor fracture. And if you look for the pubic rami, you can see also the fractures of the superior and inferior pubic rami. And this is a right-sided windswept pelvic fracture. You see the fractures of the superior and inferior pubic rami, fracture of the iliac bone and disruption of the sacroiliac joint, while on the left side you can see the open book injury with some diastasis of the sacroiliac joint and disruption of the pubic symphysis. And as stated in the literature, the lateral compression force on the right hemipelvis has transmitted across the left hemipelvis. Then the book is closed on the right side and is opened on the left side. And the vertical shear fracture, which is a very bad fracture according to the video, you see fractures of the pubic rami with disruption of the sacroiliac joint with a very high risk of bleeding in this particular type of fracture. And you can appreciate this fracture by um, identifying fracture of the superior and inferior pubic rami as well as fracture in the ipsilateral pubic bone. And this is another example of this type of fracture, vertical shear injury. You can see fractures of the superior and inferior pubic rami as well as fracture of the ipsilateral iliac bone. You can see also the fracture by CT, especially in the reformatted images. Here you see the fracture of the superior pubic ramus and fracture or comminuted fracture of the left iliac bone with disruption of the ipsilateral sacroiliac joint. Now we came to the hip dislocations, which are most commonly occur in the posterior direction in more than 90% of the cases, and this is commonly a car accident injury with compression of the knee against the dashboard, resulting in posterior dislocation of the hip. In 10% of the patients, the sciatic nerve is injured according to this type of trauma. Then, if you have the plain X-ray of the pelvis, you may identify these four items. Number one, the femoral head is displaced laterally and is superior to the acetabulum. Number two, the posterior rim of the acetabulum may be fractured. Number three, the femur is in an internal rotation and adduction. And finally, if you look carefully here, and you will see that the femoral head looks smaller compared to the non-dislocated femoral head because this head is dislocated posteriorly and now is nearer to the film compared to this femoral head. Then you got some magnification here and you got less magnification there. Then that's why the dislocated femoral head looks smaller compared to the non-dislocated one. And posterior dislocation is common and is usually secondary to motor car accident. And the associated injuries include acetabular fractures, damaging of the blood supply of the femoral head, and sciatic nerve injuries in 10% of the cases, and also injuries in the knee, especially posterior cruciate ligament tear. And this is an example of the classic posterior dislocation of the hip joint with displacement of the femoral head superior and lateral to the acetabulum, internal rotation and adduction of the femur, and there may be a fracture of the posterior acetabulum rim. The dislocation can also involve replace the hip joint, and you see this dislocation of the total hip prosthesis. The complications of hip dislocation, as I have mentioned, include uh, sciatic nerve injuries and post-traumatic osteoarthritis of the hip, femoral neck and shaft fractures, knee joint injuries, and this is a statement in the literature that the femoral head injury has a 100% risk of a vascular necrosis if the dislocation lasts more than 12 hours. Then we came to the slip decapital femoral epiphysis, and this is one of the commonest hip abnormalities in adolescents, and there is an incidence of bilateral involvement in about 20% of the cases. And there are this type of fracture is considered as type 1 Salter-Harris injury affecting the growth plate between the epiphysis and the metaphysis. There are some of the risk factors, especially obesity, hypothyroidism, hypopituitarism, and hyperparathyroidism. And uh, the slip, the capital femoral epiphysis is usually, the slippage is usually posterior and medial. If it is minor, it may be missed in the frontal view of the pelvis, but it can be detected in the frog lateral view. And this is known as a metaphyseal planche sign, which is an increased density in the proximal metaphysis, representing an attempt of healing occurring before the epiphysis is displaced. Then the findings will include widening of the gross plate devices, irregularity and the blurring of the physial edges, and demineralization or some loss of bone density of the metaphysis. And the slippage occurs post-remedial, as I have mentioned. The cause is usually unknown, but there are predisposing factors, including obesity, and sometimes are post-traumatic. Bilaterality is seen in about 20% of the cases. One of the known complications is avascular necrosis of the femoral head. This is the normal appearance of the capital femoral epiphysis by CT, and this is the slipped epiphysis on the left side. And this is one of the ways to predict the slipped capital femoral epiphysis from the frontal radiograph of the pelvis is just to draw a line uh, 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 which is going along the lateral border of the femoral neck. This line will include part of the epiphysis if the epiphysis is in its normal side. But if the epiphysis is slipped or starting to slip, this line will fail to include part of the epiphysis. And these are the grading of the uh, epiphyseal slippage. In normal conditions, you remember this line along the lateral edge of the femoral neck will intersect part of the epiphysis. In the pre-slip stage, you got only widening of the physeal plate. Then we have three degrees, the mild degree, the moderate degree, and the severe degree. And this is less than one fourth of the surface of the metaphysis, more than one fourth of the surface of the metaphysis, and more than half of the surface of the metaphysis is considered a severe degree of slippage. And this is the moderate degree of slip capital femoral epiphysis, which is evident in this frontal radiograph of the pelvis. This patient with renal failure and renal osteodystrophy, you see bilateral slippage of the capital femoral epiphysis. And this is also slip the capital femoral epiphysis on the left side, clearly seen in the frontal radiograph of the pelvis. The complications of sleep capital femoral epiphysis may include osteoarthritis of the hip, avascular necrosis of the femoral head, chondrolysis, acute cartilage necrosis of devices, and deformity with lip hence discrepancy. Then we came to the proximal femoral fractures, and it is known that the femoral neck is the weakest part of the femur, and this type of fracture tend to occur in old patients, similar to the fracture of the proximal part of the humerus. And these patients are usually osteoporotic. In younger patients, this fracture requires a high energy trauma like that is sustained in car accidents. Patients present with shortened, externally rotated limb. And fractures of the femoral neck may disrupt the blood supply to the femoral head, resulting in vascular necrosis. These are the types of femoral neck fractures, including the subcapital, transcervical, basicervical. All these fractures are inside the joint. They are intra-articular, while the intertrochanteric fracture and subtrochanteric fracture are extra-articular or extracapsular. And this is once more the difference between the intra-articular or intracapsular fractures, these three, and the extracapsular fractures, the other two. And in the previous days, we used to use the Shenton line as an indicator for disruption in the region of the hip joint, especially in the children with congenital hip dislocation and also in adults with a suspected femoral neck fracture. and the integrity of the Shenton line, which passes through the inferior border of the superior pubicramus reaching the neck of the femur and the proximal shaft, is an indicator that the hip is most likely in a good situation. These are the types of femoral neck fractures. Number one is, or stage one or type one, according to Garden classification, incomplete or impacted fracture with valgus angulation of the distal fragment, incomplete undisplaced fracture, incomplete partially displaced, incomplete totally displaced. And this is the Gordon type 1 fracture with impaction. You see some rotation of the femoral head, and you can appreciate the fracture line, the impacted fracture line in the femoral neck. And this is Gordon type 4 fracture with severe displacement of the proximal fragment. And of course, if you try to draw the Shenton line, you will see that is totally disrupted. And femoral neck fractures are treated in elderly. The non-displaced fractures are treated with screw fixation and restricted weight bearing, while the displaced fractures are treated by hemiarthroplasty or total hip replacement. Non-operative treatment is reserved for patients who are uh, uh, have some risks for surgery, and the non-operative treatment carries a 1-year mortality of up 80% of the patients due to urinary tract sepsis, pneumonia, deep vein thrombosis, pulmonary embolism, and bed sores or decubitus ulcers. And these are the ways for fixation of intertrochanteric fractures. Either you use the compression hip screw with side plate like this one, or you use the cephalomedullary nail like this one. And this is an intertrochanteric fracture, which is considered an extracapsular fracture going through the greater and lesser tuberosity with some displacement, as you can see here. And this is a subtrochanteric fracture. It occurs distal to the level of the trochanters. The subtrochanteric fractures uh, uh, these fractures occur distal to the lesser tuberosity, and they do not involve the trochanters, and you got flexion and abduction of the proximal fragment because of the action of the muscles here. They will distract this fragment like this, and adduction and shortening of the distal fragment. And this is the mechanism of the muscle effect on the fracture. The muscles of the pelvis and the iliopsoas will pull the proximal fragment like this, and the adductors will pull the distal fragment like this. And this is the way of fixation of this subtrochanteric fracture. There are many types of subtrochanteric fractures, including the simple types and the comminuted types. All what we need is just to number one, say if the fracture is a single line or comminuted. Number two, if it is significantly displaced or not. Number three, if the fracture extends proximally reaching the femoral neck or not. Then distal femoral fractures or supracondylar fractures also have a lot of classifications, and they require a high energy force so that these fractures are many times they are comminuted. There is a risk of femoral artery injury, and the fracture may extend to involve the articular surface. And you remember, this is one of the bad issues concerning any fracture, is that its extension to the articular surface. And extra-articular fractures like this type 1A, type A1, A2, and A3, simple or branching or comminuted. And this is an intra-articular fracture reaching the articular surface of the femur. And if it is involves the lateral condyle, this is type B1. Affecting the medial condyle, this is type B2. And affecting the frontal blade, and this is type B3. The fracture, if it is comminuted and reaching the articular surface, you have type C1, which affects both condyles, type C2, which affects both condyles with metaphyseal comminution, and type C3, which is a severely comminuted fracture. This fracture is considered according to the Salter-Harris classification type 2. You see a fracture proximal to the physial blade with some disruption of the physis, and this is also a comminuted supracondylar fracture of the femur in an adult reaching the articular surface, and you can see this very nicely by the reconstructed and axial CT images as well. This is the way of fixation of these fractures. There are many fixing devices like the angle blade, condylar dynamic screw, supracondylar interlocking nail, and buttress plating or locking plate. Then anatomic restoration of the fracture fragments is mandatory to prevent post-traumatic arthritis, especially in cases the fracture is reaching the articular surface. Rigid fixation is necessary, and early motion should start within 3 days of the fixation. Weight bearing is usually delayed for about 3 months. And this is what is known as the non-contact bridging plate, which is one of the fixating devices for this type of fracture. You see, the fracture first was internally fixed by this plate and the screws. Then the plate has been broken and it's replaced by this one, also with addition of some wires, and you got a appreciable callus formation around the fracture fragment. Then the Pellegrini stida lesion is a post-traumatic lesion along the medial collateral ligament. This this lesion appears in the plain X-ray as a calcified lesion, or sometimes they may consider it as a ship fracture of the medial femoral condyle, or an avulsion injury of the medial collateral ligament. Calcification of this lesion starts a few weeks after injury, and most of the patients are asymptomatic, and some of them may complain of knee pain. And this is the classic appearance of Pellegrini-Stida lesion with a calcified lesion along the course of the medial collateral ligament or near to the medial femoral condyle. Alhamdulillah Rabbil Alameen. Thank you very much.